Hi, this is Dr. Cotty, and we are going to talk about therapeutic relationships and communication. Here are the objectives for this lecture. Identify steps in gathering information for the nursing process. Identify components of nonverbal expression. Describe therapeutic and non-therapeutic communication strategy. And describe motivational interviewing and active listening. There are three primary levels of communication. So intrapersonal communication occurs within ourselves. It's us talking to ourselves. And it allows us to critical think, assess situations. Interpersonal communication occurs between two or more people. And that, again, is the exchange of information between either two people or a group. Public communication is within large groups of people. So, for example, in a classroom or community setting. Transpersonal communication addresses an individual's spiritual needs and provides interventions to meet those needs. So therapeutic communication uses assessment skills. It has a sound knowledge base, and it uses our personal strengths. It promotes compassion and respect to foster the client's highest level of functioning. Why? We want to help our clients solve their current problems. We want them to cope more effectively, and we want them to achieve treatment goals. The nurse-client relationship is the foundation on which psychiatric nursing is established. It's based on caring, trust, respect, confidentiality, and positive regard. The therapeutic relationship is the process by which nurses provide care for clients in need of psychosocial intervention. And trust involves choosing to take the risk of sharing and exposing oneself. So it leaves somebody feeling really vulnerable. So when you're in clinicals, you have to remember we do not talk about clients in the hallways. We don't talk about clients when we leave, only in post-conference. The client is given the choice. Do you wish to talk to me? I am a student nurse. It's totally up to you. We are there for the client's benefit. So the therapeutic communication is the purposeful use of communication to build and maintain relationships with the clients, their families, and their significant others. We want to elicit the client's thoughts, feelings, concerns, and needs, express empathy, obtain information and give feedback about the client's condition, intervene to promote functional behavior and effective interpersonal relationships, and evaluate their progress towards these goals and outcomes. So remember, it's client-centered, not social or reciprocal, and it's purposeful, planned, and goal-directed. So psychiatric clinicals are probably unlike any other nursing clinical that you have done because one of our main forms of treatment is communication. Your role is to be more than just a friendly neighbor who cares. A nurse and patient do not hold equal positions in the relationship. The nurse is not in the situation to get better. The client needs and goals are the priority. You're not better than the client. You're just there to help guide them. We want to have good therapeutic boundaries. This means that our communication needs to be purposeful and goal-directed, client-centered, time-limited, and professional. We need to set clear boundaries. This could be physical boundaries, psychological boundaries, or social boundaries. So time, be specific. I'll be back in 20 minutes. Or we're going to sit down and let's work on this worksheet for the next 10 minutes. When we're thinking about boundaries, how much do we say about ourselves? The answer is as little as possible. You do not want to share any information about where you live, where you grew up, where you've been to school. Are you married? Do you have children? You are a student in Columbus, and you're not there to talk about yourself. One of the most important reasons why is because the more you talk about yourself, the less the patient can tell you what's going on. We are really here to listen. So if you want to talk about if he says that he has a cat he really misses and you have a cat and you think that earns the client's trust, that would be okay. You live in Columbus and you're a student. That is okay. But not where your favorite restaurant is or where you go to the gym. And you also don't want to have personal conversations where our patients can hear us or they can hear us talking. So in addition, when it comes to physical boundaries, often we want to sit on the opposite side of the table, closest to the door. We don't want to be alone in rooms with patients. And hugging a client is likely off limits. So at Twin Valley, the rule is no hugging. At Mount Carmel and 3 West, I think that a client can initiate a hug when they're discharged. So you want to be really careful about physical touch. You want to have professional boundaries. There's 6 essential elements to a therapeutic relationship. We need to establish trust, and we need to be professional. That includes being self-aware. We want to have good rapport and mutual respect. That includes with the family members. We want to have unconditional positive regard. So what does that mean? If a client tells you something that you find shocking or perhaps you feel judgmental about, you want to become self-aware and treat that client in a caring way with unconditional positive regard. If a client talks poorly about a family member or, say, a nurse on the unit, we don't want to agree. We want to say something like, I hear you. So this is a partnership. There are 3 phases that we're going to discuss now of a therapeutic relationship. They're orientation or introductory. The middle phase is working, and the final phase is termination. So we're going to introduce ourselves to the client and state our purpose. I'm Michelle. I am a student nurse from my nursing school, and I am here today to work with you on positive coping skills, for example. Would that be okay if we work together? We want to set a contract, a meeting time, a place, frequency, duration, and a termination date. So I'm going to be here today and tomorrow until 5 p.m. We want to discuss confidentiality and build trust. Part of that trust, though, is establishing expectations and boundaries. We want to set goals with the client, explore their ideas, issues, and needs, and we want to make sure we enforce limits if there are any inappropriate behaviors. In the working relationship, we want to make sure that we're doing what we said in the orientation phase, which is kind of like our verbal contract. We want to perform assessments if needed and plan therapeutic measures. So if the client expresses needs and issues like towels or soap, or they need a phone number for a therapist, we can work with staff to help facilitate getting the client's needs met. We want to encourage the client to problem solve. We want to promote their client's self-esteem. So you're doing a great job. Foster positive behavioral change. Let's say a client blows up at a staff member and you're talking to the individual later and they're showing remorse, and you can say something like, perhaps you could try that again later with the staff member and have a redo. And we'll talk about nonviolent communication techniques later. So we want to facilitate positive behavioral change. You can also ask a question like, what could you have done differently? We want to recognize transference and counter transference issues, and we'll review those again. And we want to assess the client's problems and goals and revise the plan if necessary. We want to support the client's adaptive alternatives in their use of their new coping skill. And we want to remind them about the time of termination. At termination, we want to provide the client the opportunity to discuss thoughts and feelings about the termination. Sometimes this leads to the client discussing previous experiences with separations and loss. Summarize the goals and achievements and review the work from the session. Validate the client's feelings and discuss ways for the client to incorporate new healthy behaviors into life. And maintain the limits of the termination. The transactional model of communication is simply the exchange of messages between a sender and a receiver. And each person takes turns sending or receiving messages. So both individuals are known as communicators, and their role reverses each time in the communication process as both processes of sending and receiving occurs at the same time. So to keep the communication alive, they depend on each other. There are many factors that directly or indirectly affect the communication process in this transactional model. And those are listed here. So those include values, attitudes, culture, knowledge, religion, gender, age, and social status. There are other things that may also impact communication between the sender and receiver. And being self-aware of your own values, attitudes, cultural background, knowledge, religion, gender, age, and social status are important when you are communicating with your patient. Nonverbal communication. So nurses need to be aware of how they communicate non-verbally. We should also assess the client's nonverbal communication and see what message is being conveyed. So that might be the body posture or position, what they're wearing, a facial expression, a touch and or gesture, and the distance between the client and nurse. Facial expressions, eye contact, sounds, silence, personal space, all of these factors are part of nonverbal communication. Now let's discuss obstacles to establishing a therapeutic relationship. A judgmental attitude would definitely be an obstacle. Excessive probing, lack of self-awareness, inappropriate self-disclosure, a stress or a non-therapeutic environment, and transference or countertransference. And remember, transference includes feelings that the client developed towards the therapist or provider in relationship to similar feelings towards significant individuals in the client's early childhood. Countertransference is when that happens in the direction from the provider to the client. So boundary violations. If a nurse or a student nurse or a healthcare professional goes outside the boundaries of the therapeutic relationship and establishes social, economic, or personal relationship with the client, that is a boundary violation. So if they reach out to you on Facebook, do not accept the request and hide your profile. If you say something accidentally or you overshare, know it, claim it, discuss it with us. If you continue to have boundary violations with clients, it may be a sign that you need therapy yourself, and there are some things to work through. So self-awareness is the key. There is a difference between social communication and therapeutic communication. So social communication the purpose of that is companionship, recreational, maybe supportive. It's more equal and there's a give and take. Maybe there's a discussion of superficial topics like sports or the weather. Maybe social communication includes arguments or conflict, and it might be a relationship that fades altogether or ends abruptly. These types of communication can also be long-lasting. And a therapeutic communication, it's purposeful, and we promote health and behavior change and growth. So it's the nurse caring for the client. We want to set limits, listen, be calm and professional, and terminate the relationship. So it's a planned termination. Elements of therapeutic communication. Listening is an important element. Focus on the client's facial expressions. This requires energy. It allows the clients to determine the content and level of disclosure. And we want to be empathetic and objective. Assertiveness. So we want to be respectful while discussing what one feels and speaking from our own adult ego state. We want to use I statements for the client. Limit setting. We want to be firm, but not belittling. We do not want to criticize. We want to state the change that we want to see. So for example, I want you to stop using the bad language, or please put the chair down. Therapeutic communication includes broad, opening, or open-ended questions. So these are questions that don't end with a yes or no answer. We want to offer leads, paraphrase or summarize what the individual says, reflecting their feeling, restating the obvious, focusing, voicing doubt if we are trying to present reality, ask clarifying questions, validate their feelings, help place events, for example, on a timeline of what happened, provide information, formulate a plan, sit in silence and offer yourself to listen. So silence allows for meaningful reflection, and it allows you to be an active listener. The open-ended questions allows for more interactive discussion. When you are clarifying something, there are different clarifying techniques you can use. You can restate using the client's exact words. You can reflect, so this directs the focus back to the client so that they can examine their own feelings. Paraphrase, so that by restating the client's feelings and thoughts, the client can confirm what has been communicated. And explore the topic together so that you can gather more information. When we focus, we help the client concentrate on what is important. Now let's talk about non-therapeutic communication. Socially responding would be considered non-therapeutic. Closed-ended questions, changing the subject, belittling, stereotyped comments, false reassurance, moralizing or advising, challenging or defending, interrupting, questions that start with why. And be careful with saying, I feel. Which of the following is a barrier to therapeutic communication? Offering advice, reflective meaning, listening attentively, or giving information. You might find yourself asking, what is the difference between giving advice and giving information? Well, giving advice tends to interfere with the client's ability to make personal decisions and choices. Telling a client what to do about an abusive spouse is very different than giving information on protective shelters. So offering advice is a barrier to therapeutic communication. How do you begin a therapeutic relationship at clinicals? Hello, Mr. Jones. My name is Michelle, and I am a nursing student. I would like to spend time with you while I am here to work with you on your goals. Would that be okay? Remember, the patient is the primary focus of interaction. A professional attitude sets the tone of the therapeutic relationship. Only use self-disclosure if there's a therapeutic purpose and a boundary is in place. Maintain patient confidentiality. Avoid social relationships with patients. Avoid making judgments and giving advice. An important part of nursing is prioritization. So on a unit, which patients should get the priority first? We always want to start with patients who are unsafe to self or others, or who are labile. Patients with high anxiety or with psychosis might be a priority. People who are under the influence of alcohol or drugs or are going through withdrawal, and patients who are paranoid. We also want to make sure we get to spend time with families if they happen to be visiting, so that we can have therapeutic communication and support both the family and the patient. We don't want to miss out on those opportunities. In these priority situations, we need to be very careful when approaching these patients for everyone's safety. So an example would be if a client was cutting herself with something that she'd found on the unit, we would state something like, "I need help," and then look to the patient and say, "Please put that down." We would never intervene on our own. So you are not to put yourself in an unsafe situation. And if you need help, you need to use the word help. I need help. Studies show that unless you use the word help, many times people don't respond. Motivational interviewing is a technique to engage the client in behavior change. It begins with asking open-ended questions. Next is affirming. So we want to look at individuals' positive qualities, help improve their confidence, and focus on their strengths. Next, we teach the patient to reflect on their feelings and their behaviors. And then we summarize. We restate what we've discussed back to the client. And I don't know where I heard this quote, but we know what we believe when we hear what we say. So have you ever been around a person and when they've made a mistake, they'll say, "Oh, I'm such an idiot." Well, if they hear what they were saying, they would know what they believed. So we want to summarize and restate back to the client. Let's do a few more self-checks. When a family asks a nurse for reassurance about a client's condition, which of the following is an appropriate response? "I think your son is getting better. What have you noticed?" "I'm sure everything will be okay. It takes time to heal." "I'm unsure. Have you asked the doctor?" "I understand your concern. Let's discuss what concerns you specifically." So a therapeutic response reflects on and accepts the family's feelings, and some of these responses interject the nurse's opinion. So the appropriate answer would be D. Which statement is true about countertransference? Countertransference refers to the unconscious response of the patient to the nurse. Countertransference reactions are always unpredictable and a detriment to the nurse-patient relationship. Only positive countertransference reactions can be used therapeutically by the nurse. Negative transference reactions may arise from unresolved issues with people from the nurse's past. So take a moment and look those over. So countertransference reactions may arise from unresolved issues with people from the nurse's past. A client tells you she is afraid to quit her stressful job at a daycare center because she doesn't think she has any marketable skills. Which therapeutic communication technique would be helpful to use in this situation? A, clarifying. B, offering a general lead. C, focusing. Or D, voicing doubt. The answer is D. You would want to voice doubt that she does not have any marketable skills. So for example, you might say, I bet you have many marketable skills. Let's think of some of the things you are good at. What are some of your strengths? That would be voicing doubt. A client tells you she is very nervous about breaking up with her abusive partner and says she doesn't know if she can do it. Later that evening, you hear the client on the unit phone telling her partner that she no longer wants to see him. What is the best therapeutic response? Way to go. You really surprised me there. What will you do now? I overheard you telling your partner that you would no longer see him. How are you feeling? How did you find the courage to break up with your abusive boyfriend? The answer is C. We want to make an observation. I overheard you tell your partner that you would no longer see him. How are you feeling?
And that is the references.